Hi everyone, welcome back to the channel. Today we're going to learn how to systematically read a chest x-ray using the DRS-ABCDE method. Before we start reading chest x-rays, here's a quick look at how they work. X-rays pass through the body and get absorbed differently depending on the tissue density. The denser the tissue, the wider it appears. Here's a quick breakdown from the darkest to the brightest. Air, like in the lungs, appears black, since it lets X-ray pass through completely. Fat, slightly more dense than air, shows up as dark gray. Soft tissue, like the heart or muscles, appears as medium gray. Bone, which absorbs more X-rays, looks white. And finally, metal, like pacemakers or surgical clips, is the most dense and appears bright white. Now let's go through each step of the DRS-ABCDE system. D stands for details. Always verify the patient's name and date of birth. Check the date of the exam. Are you comparing with old films? Is this a new change or a chronic finding? Next, confirm the projection. Is it an AP, anterior-posterior, or PA, posterior-anterior view? In a PA view, the X-ray beam enters from the patient's back and exits through the front. This is the standard and preferred view for ambulatory patients because it provides the most accurate representation of heart and lung size. In contrast, an AP view means the beam travels from the front to the back. This view is typically used for patients who are supine and cannot stand, such as in ICU settings. To distinguish between PA and AP views, look at three clues: the clavicles, the scapula, and the gastric bubble. In a PA view, the clavicles are lower, usually projected over the third and fourth posterior ribs. Whereas in an AP view, the clavicles appear more elevated, often projecting over the lung apices. In a PA view, the scapula are rotated outward away from the lung fields, because the patient is instructed to roll their shoulders forward. Whereas in an AP view, the scapulae are usually over the lung fields. Lastly, in an AP view, you can usually see the gastric bubble clearly below the left hemidiaphragm. Whereas in AP views, the gastric bubble may be absent or displayed due to patient position or technical factors. Next, R stands for rotation and the overall image quality. We need to make sure the image itself is reliable. There are three things we always look for: rotation, inspiration, and penetration. First, rotation. Check if the medial ends of the clavicles are evenly spaced from the spinous processes. If they're not symmetrical, the patient might be rotated, which can throw off your assessment of the heart and mediastinum. Next, inspiration. Count the posterior ribs. These are the ones that run more or less horizontally across the film and are easier to see. Ideally, you want to see at least 9 posterior ribs above the diaphragm in a good PA film. Finally, penetration. You should be able to see the vertebral bodies faintly through the heart shadow. And the trachea, carina, and lung markings behind the heart should also be visible. Next, let's take a look at the soft tissues and bones. Start by scanning the soft tissues. Look at the neck, chest wall, and breast shadows. You want to check for symmetry, signs of subcutaneous air, or any unexpected masses. If you notice streaky or bubbly dark areas in the soft tissues, especially around the neck or chest wall, that could be subcutaneous air. This usually means subcutaneous emphysema, which is when air leaks into the layer just under the skin. It often indicates trauma or air leak, like from a pneumothorax or ruptured airway. If you notice a rounded opacity in the chest wall or neck, think about benign tumors like lipomas or neurofibromas. In neurofibromatosis, you might see multiple soft tissue masses along the nerve pathways. Then move on to the bones. Go through the clavicles, ribs, sternum, spine, and shoulders. A normal chest x-ray should show good symmetry, no fractures, dislocations, or lytic lesions. Look closely along each rib. A fracture might appear as a sharp break in the cortex or a step-up in the contour. Now let's examine A for airway. First, check if the trachea is midline. Deviation from the midline is always a red flag, and the direction of the shift can give you important diagnostic clues. If the trachea is pulled towards the involved side, it usually means there's a volume loss, like in atelectasis, which is when part of the lung collapses and shrinks. If the trachea is pushed away from the involved side, think of things that increase pressure, like a tumor, a large pleural effusion, or a tension pneumothorax. Next, look at the carina, where the trachea splits into the left and right bronchi. Normally, the carinal angle is about 60 to 90 degrees. A widened carina can suggest left atrial enlargement from heart failure, subcarinal lymphadenopathy from infections or cancer, or even a mediastinal mass pushing the bronchi apart. Next, let's move on to B for breathing. This includes the lung fields, the hilum, and the pleura. Start by inspecting the lung fields on both sides. You're looking for symmetry, normal aeration, and any abnormal opacities. Consolidation appears as a dense white area that obscures the normal lung markings. It can penetrate different types of material filling the alveoli, such as pus from pneumonia, water from pulmonary edema, blood from pulmonary hemorrhage, and cells in the tumor. Next, take a look at the hilum. That's the central region where major structures enter and exit the lungs. It includes the pulmonary arteries and veins, the main bronchi, lymph nodes, and bronchial vessels. On a chest X-ray, it appears as a soft triangular shadow near the center of each lung, just beside the mediastinum. Normally, the left hilum sits slightly higher than the right, and both should look symmetrical, not too large, not too dense. But if the hilum looks abnormal or enlarged, we can use the mnemonic hilum to remember the common causes. H stands for hilar mass. This could be a lung tumor like bronchogenic carcinoma or a benign growth. I stands for infections such as tuberculosis, which can cause reactive enlargement of hilar nodes. L stands for lymphadenopathy, abbreviated as LAD, seen in sarcoidosis and lymphoma. U stands for unusual vessels, like in pulmonary hypertension where the pulmonary arteries are abnormally dilated. And M stands for metastasis. Cancers from breast, colon, or kidney can spread to the hilar region. Now let's check the pleura, the lining around each lung. It's usually visible unless there's something abnormal like air or fluid. In the tension pneumothorax, look for visible pleural line with no lung markings beyond it. Now let's move on to C, which stands for cardiac and mediastinum. Start by looking at the cardiac silhouette. On a PA chest X-ray, we assess the heart size using the cardiothoracic ratio. This is the width of the heart divided by the width of the chest. A ratio greater than 0.5 on a PA view or a ratio greater than 0.6 on an AP view suggests cardiomegaly, or an enlarged heart, which may occur in heart failure. Next, examine the mediastinum. That's the central area between the lungs, containing the heart, great vessels, trachea, and esophagus. A widened mediastinum, usually defined as more than 8 cm on a PA view, can suggest serious conditions like aortic dissection, which happens when there's a tear in the inner wall of the aorta, causing blood to split the layers of the vessel, or a mass such as lymphoma or thymoma. Next, take a look at the diaphragm. Normally, the right hemidiaphragm sits slightly higher than the left, due to the liver underneath. The diaphragm is normally dome-shaped. When it appears flat or depressed, that usually indicates increased pressure inside the chest pushing it downward. Common causes include emphysema, tension pneumothorax, and severe asthma attack. Check the costal phrenic angles, or CP angle, where the diaphragm meets the chest wall. They should be sharp and clear. If they're blunted, it often means there's fluid in the pleural space, like a pleural effusion. And if you spot air under the diaphragm, that's called subdiaphragmatic free air, which usually means bowel perforation, a surgical emergency. Finally, let's wrap up with E for extras. This is where you look for any tubes, lines, or devices that show up on the X-ray. The tip of the endotracheal tube should sit about 3 to 5 centimeters above the carina. If it's too high, the patient may not be ventilated properly. And if it's too low, it might enter one bronchus. The nasogastric tube should pass down the midline, through the esophagus, and the tip should be seen below the diaphragm in the stomach. If it coils in the chest or stops early, that's malpositioned. And a properly placed central venous catheter should have its tip in the superior vena cava, just above the right atrium, usually around the level of the carina. If you see a pacemaker device, identify the pulse generator first, usually seen over the left chest wall. Then look for the leads. One should go to the right atrium and another to the right ventricle. Occasionally, there may also be a biventricular or ICD lead. And that wraps up a quick guide to reading a chest x-ray. Thanks for watching, and I'll see you in the next one.